Okay, well, let's get started. Welcome, everyone, to the West Michigan Hospice and Palliative Medicine Fellowship Consortium. It's a pleasure to be with you today, and I'm the program director at the Kalamazoo site, Western Michigan School of Medicine. And today we're going to talk about pain management, particularly expanding on the concepts that were outlined last week. So specifically, we'll briefly touch on a pain assessment tool in those who are nonverbal, as well as identifying non-opioid, but particularly focusing on opioid-based approaches to pain management in palliative care patients, so you can become more comfortable knowing which medicines, what some of the nuances are of the different medicines, and then also focusing on dose conversions, and then identifying common options for treating refractory pain. I'd like to start off with two cases. One is a man with COPD, lung cancer, chronic low back pain with bone mets, but also underlying degenerative disc disease. He's been on long-acting morphine, 30 milligrams twice a day, and PRN oxycodone acetaminophen, admitted with pneumonia and sepsis, severe dyspnea, fever, cough. They held the opioids on admission because he was too sleepy. His back pain has been worsening since then. Another case would be an example of a woman admitted to the inpatient rehab unit following major trauma and multiple surgeries, and pain is interfering with her ability to do rehab. And so we were consulted to try to help get her pain under control. So as mentioned last week, pain assessment is very important, and pain can be a terrible thing and really interfere with quality of life. So just to review from last week, take time for a comprehensive pain history, listen, establish trust. That's probably the most important thing, is believe your patients and try to understand where they're coming from, what their pain experience has been, and how it affects their life. And also understand that there are many variables that can make people either more or less prone to report pain or even experience pain. Assessing the diagnoses, etiology, comorbidities, and reviewing their past and current treatments and how effective they've been. And then, of course, being alert to coexisting psychiatric conditions, prior trauma, abuse, or substance abuse, all of which seem to magnify the pain. As mentioned last week, the concept of total pain, and this is something that's really mainly talked about in the palliative care literature rather than general literature, but basically pain is worsened by anything that can affect their life, their quality of life. So sleep, fatigue, psychiatric and psychological conditions, financial stresses, spiritual distress or spiritual pain. And pain may affect function, relationships, mood, sleep, quality of life, and enjoyment of life. And it gets complicated trying to assess pain in people who can't tell you more about their pain. So if they're on a ventilator, if they have altered mentation, they may not be able to tell you they have pain. And so a lot of times we just have to make an educated guess. We have to have a high index of suspicion for pain. And don't assume that just because they're lying there in the bed asleep doesn't mean they don't have some pain, or that they're anxious or restless, therefore they must be in pain. Sometimes that can be the case, not always. Family or staff may perceive pain and suffering, and so if they know the patient well and know that, this is somebody who, when they're in pain, this is how they respond, and it's helpful to know that. Only really in acute pain do you see elevated vital signs. This is especially true in the ICU. Heart rate, blood pressure, respiratory rate. Chronic pain, you're usually going to see normal vital signs. Last week, Dr. Mulder mentioned the behavioral pain score and the CPOT, critical care pain observation tool. These are tools that are found in the electronic medical record. Nurses use them. The differences are that, they look at behavioral signs, but the BPS is a 0 to 8 scale, CPOT is 0 to 12. Wouldn't it be nice if we had a 0 to 10 scale? We're all used to the rating pain on a 10 scale. Well, actually, we do. Dr. Mulder mentioned this last week. I'm just going to briefly mention it as well, just to reinforce that I think it's a very useful and it's a validated tool, not only in dementia, but also in other nonverbal patients. The nice thing is it's quantifiable, it's 0 out of 10, and you can follow it over time. And it looks at 5 areas, each scored 0 to 2, 0 being normal, 2 being severe: breathing, negative vocalization, facial expression, body language, and consolability. So I want to now focus on the meat of the talk, which is pain management. How do you get pain under control? How do you make the patient comfortable? So obviously, seeing each patient as an individual, setting realistic, individualized goals, really focusing on not just improving the pain, but the quality of life and the functional status. It's oftentimes, especially with chronic pain, it's more of a coping rather than cure, helping them live despite the pain, rather than trying to strive for a 0 out of 10 on the pain scale, because sometimes the only way to get that is for the patient to be completely asleep. Consider the causes of the pain, the type of pain, the severity, the duration and timing of the pain, and of course, treat the whole person. Look for underlying depression, anxiety, which tend to magnify or turn up the volume on the pain. Remember that total pain slide? It had the volume knob of a stereo. And so oftentimes just sitting down and listening to the patient in and of itself can help turn that volume knob down. And then addressing their underlying mental and psychosocial, spiritual health can help. Obviously, if you're going to be prescribing opioids, you want to make sure you discuss the risks and benefits with them, and do an appropriate screen to make sure that they're not high risk for opioid use or opioid abuse or diversion. And follow up closely to assess safety, efficacy, and consider an empiric trial, a time-limited trial, if you will. So before we talk about opioids, and again, this is a lot of this is review from last week, but just to reinforce the points that Dr. Mulder made, there are many ways to treat pain besides opioids. So obviously physical means, so repositioning, rest, heat, ice, PT, OT, psychosocial and spiritual support, environmental cues, like instead of sitting alone in a dark room, try to encourage the patient to be more engaged in those around them, because then that will help really divert the brain's focus on the pain and get them focused outwardly instead of just inwardly. Obviously, there are procedural options as well, and those are covered later this year in one of our lectures. So nerve blocks, surgical procedures, if there's mass effect or obstruction, radiation, for instance, in metastatic disease to the spine, the brain, other parts of the body. And then pharmacologic treatments, so acetaminophen, NSAIDs, antidepressants, gabapentinoids, steroids, topical analgesics, alpha-2 blockers are all useful for treating pain. And Dr. Mulder also mentioned last week the pain types and etiologies. I just threw this up there, and these will be in the slides and the recorded talk that'll be on the YouTube site. But just to review, so generally we look at I'm not sure how to hide this taskbar from the top of my screen, but it's blocking the top of my slide. But basically, we have somatic pain, neuropathic pain, and then central or nociplastic pain. And so understanding which type of pain you're dealing with will help you tailor the medications toward medicines that will be most effective for that type of pain. Since we're focusing on opioids today, I would mention that opioids tend to be most effective for pain that's related to musculoskeletal or trauma, severe pain, metastatic disease, and then there are niches for the other, like neuropathic pain obviously has its niches, and those are mentioned in the other lecture last week. I want to briefly touch on cancer pain treatments by pain type, because we see a lot of patients with cancer, and it's helpful to know what to start with and what to do next. So in general, acetaminophen and NSAIDs are very useful. And then if the pain is more severe, moderate to severe, then and if acetaminophen or NSAIDs have failed, then opioids would be useful. Steroids, plus or minus radiation, are beneficial for bone mets and brain mets, as well as lymphangitic carcinomatosis and SVC obstruction. And it's possible they could put questions on the boards that want you to know specifically that, yes, steroids would be your first line treatment for these types of pain in someone with cancer, rather than necessarily choosing an opioid first. But certainly if the pain is severe and they need relief now, well, an opioid is going to kick in pretty quickly, even quicker than steroids. Adjunctive treatments, calcitonin, bisphosphonates, remembering GI prophylaxis as well. So visceral type of pain in malignant bowel obstruction, opioids are helpful. Anticholinergics like oxybutynin, hyoscyamine, scopolamine, steroids, octreotide, haloperidol, again, more for the anti-nausea aspect, and proton pump inhibitors. Those are all helpful, kind of a cocktail of approach for that. Neuropathic pain, especially either due to nerve impingement from the tumor or due to chemotherapy. So consider anticonvulsants like gabapentin and pregabalin, tricyclic antidepressants, SSRIs, SNRIs like duloxetine, venlafaxine, local anesthetics. If the pain is localized and fairly superficial, then lidocaine patch may be helpful, and capsaicin also. Tramadol, tapentadol, methadone, and ketamine. So when are opioids appropriate? When is it time to bring out the big guns? So basically when there's failure of non-opioids to improve function and quality of life. In other words, can the patient do the things that they need to do to function in life and have some quality of life? Or is it the pain that's holding them back? And have other means been tried and not been effective enough? If it's moderate to severe cancer pain, I think most people would agree that opioids are definitely appropriate, especially near end of life. And then if it is non-malignant pain, generally opioids are reserved for situations where the non-opioids have not worked, where the benefits are expected to outweigh the burdens. And if it's ongoing chronic pain that's uncontrolled by non-opioids, or they have contraindications to, for example, NSAIDs, then you weigh the benefits and burdens, you weigh the side effects, the risks of opioid use or diversion, and if it seems favorable, you give it a try, and you look for specific functional outcomes that will indicate that this is helping the patient more than it's hurting the patient. So again, it's not a blanket, don't use opioids in chronic pain. It's more like, well, let's evaluate the patient, figure out what treatment plan would work best for them, and then try it, and then modify the plan as time goes along to try to make sure that you're actually helping the patient improve rather than just ending up feeding an addiction, for example. It's also important to know the difference between short and long-acting opioids. So with immediate release or short-acting opioids, generally this is for acute pain or incident or breakthrough pain specific precipitated by activities. It's okay to use if they're opioid naive, if the pain is moderate to severe, and the dosing is usually as needed, especially pre-medicating before painful activities. Examples include tramadol, tapentadol, hydrocodone, oxycodone, morphine IR, hydromorphone, buprenorphine, versus the extended or sustained release or long-acting opioids. And this is really reserved for chronic or ongoing pain in people who are opioid tolerant. So you never want to start with this. You always want to start with something short-acting and then see how much they're going to need. And this, again, is for moderate to severe pain. Dosing is scheduled rather than PRN because it takes at least an hour for the dose to kick in usually. And then examples include morphine, SR, ER, fentanyl patch, oxycodone, extended release, methadone, buprenorphine patch. It's also helpful to understand some of the pharmacology of when you give a dose, when should you expect relief. So for IV, IM, and SC routes, those are considered parenteral. The onset of action can be as quick as 5 to 15 minutes. So if somebody's in a severe crisis, technically you could give the medication fairly frequently. Time to peak effect, 10 to 30 minutes. Duration of effect, 1 to 4 hours. So if you order PRN morphine every 8 or every 12 hours PRN because you're hoping to wean them off, that's probably not going to work because their pain is going to come back usually within 4 hours, unless they have renal failure, in which case it could last longer. And they're just going to suffer between hours 4 and 8 or 12. Orally, the onset of action is 15 to 45 minutes, time to peak effect 60 to 90 minutes, duration of effect 2 to 6 hours usually. The exception here would be liquid morphine, which if you give it sublingually, yeah, it can kick in within 15 minutes. So that's an important distinction between the pills versus something that's already liquid and can be absorbed submucosally. And then transdermally, this is going to take hours to take effect. So you can't just start a fentanyl patch, stop the fentanyl drip, send them out of the ICU to the medical floor, and expect that their pain is going to be well controlled. Once the drip wears off, their pain will be out of control, and it'll take hours for that patch to begin to kick in. So it often takes 6 to 12 hours for the patch to totally kick in. And oftentimes, a good day or two, and then the duration of effect is 1 to 3 days. It's also important to understand the rapidity of action of the medication. So typically fentanyl kicks in slightly faster than morphine. Hydromorphone is the longest acting, and so it's going to take a little longer to kick in, but it's going to last longer. So hydromorphone is the one opioid where you really don't want to give it more often than every 90 to 120 minutes, because otherwise it will dose stack, and then a few hours later you might end up with some respiratory depression. So that's important to know. Also, the PRN dose ranges should be proportional to the total daily dose. So a good rule is 10 to 25% of your total daily dose should be your PRN dose. So if somebody's on MS Contin, say 30 milligrams twice a day, that's 60 milligrams of oral morphine a day. Divide that by 10%, and that's 6 milligrams. Divide it by 25%, it's 15 milligrams. So your PRN dose should be somewhere between, to make the dosing easier, between 5 and 15 milligrams. And you could always do a lower dose, but make it available more often. So, 5 or 10 milligrams every hour as needed would not be unreasonable, given the total daily dosage. And if somebody's on a much lower dose for a total daily dose, then you'd want to err on the lower side for your PRN dose. But just make sure they're available often enough to be helpful to the patient. And I often will order a lower dose and a higher dose for moderate or severe breakthrough pain, and that will help the patient have some options. And that way they don't necessarily get more than what they need or consistently get underdosed if they end up needing more. And it saves phone calls in the middle of the night. So if someone is in pain that's severe, how do you get it under control quickly? Well, first of all, the most important point is bolus. Bolus the dose, because that will kick in faster. And then you can see how they respond, see if it worked. And if you need to go up, you titrate the dose to the effect. If you're looking at the patient day by day and you realize that their pain is still uncontrolled, then you can calculate the total daily dose of opioid. And this is usually done in morphine milligram equivalents, or MMEs. And if they're in mild pain that's not controlled, you can increase your total daily dose by 25%. If it's moderate pain, 50%, and severe pain, you can increase it by up to 100% of what they were on the day before. And really, there's no ceiling dose, except that's which is limited by side effects of sedation or respiratory depression. Now, sometimes people, after their pain is controlled, then they sleep. Why is that? Well, they haven't been sleeping because they've been in so much pain. So you finally get their pain controlled and they're out for hours. And people worry, oh, are we over medicating them? Well, what do you think the real test of that would be? Can you wake them up? And if you can wake them up and have a brief conversation with them, then they're probably not over medicated, especially if their respiratory rate is at least 10 to 12 per minute, then they're not over medicated. They're just catching up on sleep because they haven't had good sleep. All right, now let's change our focus and talk about how do you convert from one opioid to another. And there are many reasons to change opioids. First of all, if you're experiencing adverse effects, such as side effects like nausea, itching, or if it's just not working for that patient. There are actually 64 different genetic polymorphisms for opioid metabolism. So people literally can say, well, Dilaudid works and morphine doesn't, or vice versa. And they may be telling the truth. There may be a need for an alternate route. For instance, they're starting to develop dysphagia and they can't swallow pills anymore. So now you need to give something IV or sublingual or transdermal or something like that. Or maybe they're having organ failure, liver or kidney failure, and so you need to switch from morphine to a different medication. Or discharge plans. You want to get them off the IV medicines and onto something oral that will work and that will help them stay comfortable. There may be specifications based on what their insurance will pay for, what's on the formulary, and how costly it is. Obviously, some like the oxycodone derivatives are a lot more costly than morphine, for example. And then the process of how to convert is assessing their pain severity and chronicity. Is this something long-acting, short-acting? Is it mild, moderate, severe? Are the medicines that they're on working? Find out how effective these are, and then choose the opioid, calculate and individualize the dose, and monitor the patient. So this is the table similar to one you might see on the boards or in smartphone apps. And this is kind of the classic table. I've reorganized it to change it to order of potency. So the least potent is codeine. Morphine and hydrocodone are the same potency. Oxycodone is 1.5 times as potent as morphine and hydrocodone. And then hydromorphone is even more potent. You can see there's almost a 1-to-4 ratio, conversion ratio there. And for IV, it's about 1-to-4, 1-to-3 or so. And then fentanyl is even more potent than that. So Dr. McPherson, a few years ago, came out with this table, which is modified and updated because there's been research that has really looked at the conversion ratios. And what she found is that morphine is between oral and IV about a 5-to-2. Now, if you go back to the other table, it's about a 1-to-3 ratio, and she calculated at 5-to-2, which is 1-to-2.5. So in other words, a milligram of IV morphine is like 2.5 milligrams of Roxanol, which is the liquid form of morphine. Hydromorphone, she also calculated at 5-to-2 between oral and IV. But notice, again, between IV morphine and IV hydromorphone, there's a 5-fold difference there. And same with oral, 1-to-5. So her conversion ratio, if you're converting from hydromorphone to morphine, it looks like you would multiply by 5. I usually multiply by 4 just to be on the safe side. And part of that is this phenomenon called incomplete cross tolerance. And you're probably going to see tables like this on the boards. They do provide the table on the boards, but you just need to know how to use it, and you need to know this concept of reducing the dose by 25 to 50% because someone may respond more effectively when you switch to a different opioid. And so you don't want to over-medicate them. It's better to underdose or err on the lower side, but have adequate PRN short-acting opioids available for breakthrough pain, and then to see over the next few days if that dose ends up being the right dose. So then there's also the oxycodone and hydrocodone. So again, oxycodone is more potent than morphine or hydrocodone, which are the same potency. And then oxymorphone, which I honestly have never seen used in my practice. I think it's used more in other countries. So here's some examples. So morphine, just to make the math easier, let's see. So IV morphine 2, oral 5. So that's 1 milligram is 2.5 of oral. 1 milligram IV equals 2.5 PO. There's a pre-filled syringe of Roxanol, which is the morphine elixir. It comes as 2.5 milligrams or 5 milligrams. So that's why this is a handy conversion. Also note, once again, morphine and hydrocodone are the same. Hydromorphone is more potent. And then hydromorphone is, if I like the 1 to 10, which tends to, again, err on the lower side. It would be 1 to 12 or more if you did the Dr. McPherson's conversions. But 1 milligram of IV hydromorphone or dilaudid is the same as 10 milligrams of oral morphine. That just makes the math easier. And then, which is also the same as 10 of hydrocodone or 7.5 of oxycodone. Another helpful conversion to remember in terms of IVs is that morphine 1 milligram IV is the same as 25 micrograms of fentanyl, which is the same as 0.25 milligrams of hydromorphone. And the oral morphine elixir is given as a 2.5, 5, 10, 15, or 20, but you can measure it out in even lower amounts if you need to, but it's just tricky because the volume is so low. All right, the fentanyl patch. Let's spend some time talking about this. So this is a long-acting opioid. It's absorbed through the skin, but it's absorbed into adipose tissue, and that's important to remember. So if they're cachectic, they're probably not going to absorb it very well. It takes really at least 24 hours to get the medicine completely absorbed, and oftentimes it can even take up to 48 hours to see the full effect. But the first initial effect, you're probably not going to see within the first 6 hours. So you need to make sure that if you do start this, that you have adequate pain control, either through scheduled or PRN doses before this. The easy way to calculate the dose is take your 24-hour morphine milligram equivalent dose. In other words, add up all that they've gotten in the last 24 hours, convert it to morphine dosing based on the conversion table, and divide that by 3. And then round to the nearest 12 micrograms, and that'll give you the patch size, or the combination of patch sizes, like 25 plus 12 is 37. There's 25, there's 12, 25, 50 micrograms, 75, 100 microgram patches available. And then you dose it every 72 hours. If they're on an opioid infusion, 25 microgram fentanyl patch is going to be the same as 1 milligram per hour of IV morphine. And you're not going to want to increase the patch by more often than every 48, 72 hours, just because of the long half-life. There are other forms available of fentanyl. So there's IV, there's oral, there's buccal or intranasal. Obviously, these are probably more expensive, so we don't tend to see them as much on the inpatient side. But on the outpatient side, if somebody has decent insurance, you might see this. And the intranasal is really helpful if they have incident pain and they need relief immediately, because it will kick in pretty fast. Same thing with the buccal formulation, much faster than any oral or IV. But most of the time in the hospital, we're going to see IV fentanyl. Outpatient, you might see the fentanyl patch, and then every once in a while, you might see these. All right, let's talk about refractory pain, because this is where the rubber meets the road. 65-year-old man with stage 4 esophageal cancer who has a PEG tube. He's debilitated, he's lost weight, he's cachectic, and his pain control is worsening despite escalating his fentanyl patch, which is now 200 micrograms gradually over the last 3 months. He's asking for pain medications every 2 to 4 hours. His pain got so bad, and he developed dyspnea and anxiety, and he was just miserable. So he got admitted to the hospital, and he was noted to be distressed and uncomfortable. He was breathing 30 times a minute. His albumin was only 2, and his BMI is 17. So why is his pain out of control, and how can we help? And this is where I turn it over to the new fellows and see what you have to say.
Go ahead. Your mic is active.
Oh, okay. Probably his 20-pound weight loss and cachexia. He doesn't have as much adiposity for that to absorb properly.
Yep, you are right on. So what do you think we need to do to better control his pain?
Probably switch to IV or another form.
Would you try IV or oral right now?
Esophageal cancer. Well, he has a peg tube, so we could try through that.
Well, I
Right.
mean, he's admitted, so we could try IV just to break the pain and then transition to oral via, well, the liquid formulation via peg tube, like you said, Purvi.
Mhm. Yeah, no, those are good suggestions. So, yeah, so when you're faced with someone with uncontrolled pain despite high opioid doses, there's a lot of things you need to think about as possible causes. So they could be having an acute illness like an infection, inflammation, ischemia that is causing more pain or discomfort. Maybe the disease is progressing. Maybe the cancer is starting to invade nerves or bone or other places that is just causing a lot of pain. Or maybe they're not absorbing it well through the gut or through the skin because of either abnormal gut motility or not enough adipose tissue. Maybe they aren't responding to that type of opioid because of abnormal metabolism. Maybe the pain is just plain not responsive to opioids as much, such as neuropathic pain. Maybe there is a component of total pain, so emotional, psychological, or spiritual pain. Maybe they're developing tolerance or withdrawal or opioid-induced hyperalgesia. The so-called pseudo-addiction, which is often seen, manifested as quote-unquote drug seeking, but the term was coined by Dr. Weissman probably 20 years ago, where he noted that people whose pain was undertreated tended to exhibit drug-seeking behaviors because their pain wasn't under control and they kept wanting more in order to get the pain under control. And the way to tell this apart from opioid use disorder is when you do give them more and their pain gets under better control, do the demands decrease and do they begin to function normally? Or no matter how much you give them, they still want more, which is more of a sign of the opioid use disorder. So those are all things in your differential diagnosis when you're faced with refractory pain. And there are many management options. We can add opioids, we can increase them, we can use a more potent opioid, we could change the route of administration. We could add more of the adjunctive medications, especially if there's a component of pain like neuropathic or visceral pain that might be better served through another means, whether it be steroids or gabapentin or TCAs or other medicines like that. Or consider using an NMDA blocker if they're having severe chronic or neuropathic pain, such as methadone or ketamine. And again, we have separate lectures on covering IV infusions, covering methadone, covering ketamine later on this year. I did throw in a little bit of information at the very end after my conclusion slide on opioid infusion. So if you have access to the slides, that's in there if you need something now. But I think next week may be maybe when they're doing that lecture. So anyway, just a quick note on the opioid drips. This is for ongoing severe pain or shortness of breath, especially if, for instance, if somebody's coming off of a ventilator and with comfort care, despite giving boluses every 2 to 4 hours. The benefits: consistent pain control, it's safer and better tolerated, less sedation, less hypotension because you're spreading that dose out over an hour instead of necessarily giving it all at once. Generally, patients are better satisfied. And it's important to note, IV boluses are to achieve pain control, whereas the drips, the infusions, are helpful to maintain pain control. So if somebody is in a crisis, just turning up the drip is not going to get their pain controlled right away. It will maybe an hour or two from now. But if you want to get their pain controlled now, give a bolus and then turn up the drip so that when the bolus wears off, the drip will be in place at a higher rate. So, and again, drips are really a bridge to comfort. So in this patient, we actually did end up we gave him boluses and then eventually a drip to get his pain control because he was opioid tolerant. He was in severe pain, severe crisis, and just looked like if we didn't do something like this, he was going to have respiratory failure because he was so cachectic and breathing so fast. So he ended up taking 6 milligrams an hour of morphine in order to be comfortable. And he was totally alert and coherent. So now we have to convert him to an oral regimen. and get him able to eventually leave the hospital. So what long-acting oral or other type of opioid should we use? We've already established that fentanyl patches are not absorbed well in this gentleman because he is so cachectic, and he has a PEG tube and dysphagia because of his prior esophageal cancer. So long-acting opioids typically cannot be crushed and put in a PEG tube because they become immediate release. So morphine, oxycodone, those all become immediate release if you crush them. So is there another option that we can use? I'll turn it over to the fellows, see if they have any ideas.
Can't you get some long-acting opiates in oral pill form that have like the pellets that you can that can be opened up and administered through a PEG tube?
Yeah, most of the long-acting ones generally, it's based on the formulation rather than the intrinsic properties. So I'm wondering, can you think of an intrinsically long-acting opioid that you can crush it and it stays long-acting, or you can give it as a liquid and it stays long-acting?
You're whispering it.
Oh, methadone.
Methadone, okay. I'm glad you suggested that because that's actually what we ended up using in this gentleman, and it worked beautifully. There's another lecture on methadone, which is outstanding. So I don't want to steal the thunder. I did want to mention, though, in case you're in situations like this, before you hear that lecture, I just wanted to give you a little bit of information so that way you could be better prepared. So methadone, it's a mu agonist and NMDA antagonist. So it helps with both neuropathic pain and regular somatic pain. It's only for chronic pain and opioid tolerant patients. And it also helps with opioid hyperalgesia because of the NMDA pathway. It's potent, it's inexpensive, it's well tolerated, can be given in multiple ways, and it is the only intrinsically long-acting opioid that can be crushed or given as a liquid. It's very helpful to know that. Onset is usually within an hour because you have a little bit of short-acting effect, but most of the effect is long-acting. Duration 6 to 12 hours. It's hepatically metabolized. Elimination half-life is long, days, several days, like 4 to 5 days. Starting dose is pretty low, 2.5 milligrams every 8 to 12 hours. Conversion ratios vary depending on how much morphine milligram equivalent someone is on. So if they're on a lower amount, then it's 5 to 1 morphine to methadone. In terms of the daily dosing, and then you divide that by 2 or 3 to get your BID or TID dosing. If they're on 60 to 200 MMEs, it's 10 to 1. If greater than 200, then 20 to 1. So this gentleman was on morphine 6 milligrams per hour IV infusion over a 24-hour period. So 6 per hour times 24 times 2.5 to convert from IV to oral morphine. That gives you a total of 360 milligrams of oral MME. So now what you do is you take this number and you divide it by 20 to get 18 milligrams, and then you reduce that dose further to, because of, incomplete cross tolerance, and maybe because, that way you'll have a little bit of margin to give your short-acting medications. So that gives you about 12 to 15 milligrams total per day. Divide that by 2 to get your BID dosing, divide it by 3 to get your TID dosing, and basically you get, say, 4 to 5 milligrams 3 times a day would give you the equivalent of that. So obviously methadone is really potent and it can be given as a tablet or an elixir, and then obviously hold the medicine if their respiratory rate is dropping or if they're too sleepy. Just watch out for respiratory depression. So that's why we don't escalate morphine very quickly. Watch out for oversedation, cardiac arrhythmias like torsades, VTAC. So if they have a prolonged QT interval, don't give it if their QT is over 500. And use with caution if they're on other sedatives or on grapefruit juice, because that enhances or delays the metabolism. And then there are drugs to avoid. Again, these are things that might show up on the boards. And just in case you I know this will be covered in the methadone lecture, so I don't want to spend too much time on it, but just know that any medication that can increase your QT interval should be used with caution. If you're considering methadone, just monitor it and be cautious because of this risk. All right, so now, once they're on opioids, then how do we monitor them? What do we look for specifically to see if the opioids are working? So we look at, are the medicines working and are they experiencing any adverse effects or toxicity? So what are the benefits and what are the burdens? And we can continue the opioids as long as the benefits are outweighing the burdens. So specifically, we ask the patient, what's their pain rating? What can they do on a daily basis? What's their function like? How's their quality of life? And then objectively, we're going to look at how much are they spending, what percentage of their day are they able to get up and move around and walk? Are they able to sleep at night? Can they work? And how much of the rescue or PRN opioid are they using to try to control the pain? And then for adverse effects, we're going to look at, are they having significant side effects? Constipation, number one, it's universal. Are they having any nausea, sedation? Is it impairing their social interactions? Are they getting dizzy, having itching, hallucinations, dry mouth, urinary retention? This is one of the lesser known side effects of opioids, but it can be an issue, especially in older men with BPH. Sweating, rash, or hives. And then perhaps even counseling the patient ahead of time, making sure they're on a laxative, letting them know that if they're experiencing side effects, like give you a call or let you know. And then some of these are self-limited, like the nausea tends to be self-limited. And then objectively, we're going to look at how alert or sedated are they? Are they falling asleep mid-sentence? Do they look spacey or foggy? And if so, maybe they're a little bit, maybe you need to back off on the dose. Look at the respiratory rate. Generally, a rate between 12 and 20 is great. If it's consistently less than 12, then you really should lower the dose because they don't have much margin before it becomes too low, like when they're sleeping. Do they have pinpoint pupils, indicating maybe too much opioid? Are they, ask about their bowel movements? Are they moving their bowels? Are they having any emesis? How many hours a day are they sleeping? Do they have any signs of excoriation indicating itching? For instance, morphine is one of the most common ones that can cause itching. And it's not really a true allergy. It's more like because morphine causes direct mast cell release of histamine rather than working through an IgE allergy mediated. So technically it's not an allergy, it's a side effect. But with that said, people who itch when they take morphine are not going to want to take morphine. So you may want to use a different one. And then neurologically, confusion, evaluating their mental status, maybe also evaluating how is it affecting their memory? Are they getting spacey? Or are they starting to have things like myoclonus? Because that's one of the potential side effects of morphine is if they get too much, is that they can start getting kind of twitchy. So that's another thing to look for. All right. I'd like to focus on very important possible side effects of opioids. A 69-year-old obese man with COPD and chronic pain who's on long-acting morphine became somnolent after being outside all day in the July heat. His respiratory rate was 6, his SATs were 87%, and he was showing myoclonus. Another case is a 59-year-old woman with chronic cancer pain was given 4 milligrams of IV morphine for severe breakthrough pain, and 15 minutes later she was somnolent but arousable. And the nurse calls you and is concerned. Should I call a rapid response? Do we need to Narcan this patient? Her respiratory rate was 8, her SATs were 91%. So what should you do? A, immediately give naloxone 0.4 milligrams IV, that's 1 amp. B, give naloxone 0.04 milligrams IV. Or C, provide oxygen, monitor the patient, and wait for the opioid effects to wear off. So for the first case, which of these three would you do?
Do the naloxone for the 69-year-old, yeah.
Okay, what dose would you use?
0.4 milligrams IV.
Did you say 0.4 or 0.04?
Uh, 0.4.
Okay. So if you give the full amp to someone who is opioid tolerant and on opioids for chronic pain, what do you think that will do to their pain control?
Probably not be good for maintaining their chronic pain. So
Yeah. Is there any
Yeah.
risk of throwing them into opioid withdrawal?
yeah, especially if they're taking it chronically. That's
Yeah. Yeah. So B would be a better choice for the 69-year-old man with COPD and chronic pain. How about the lady with cancer pain who's just a little bit sleepy and SATs are, yeah, they're okay. They're above 90. What would you do in that case?
O2 and monitor.
Yeah. Yeah, the second case isn't yet life-threatening, and it might not become life-threatening as long as she's given appropriate support. This case is definitely life-threatening, the first case. So, all right, so this is what you might call a near miss. Respiratory depression is the most feared side effect of opioids, besides constipation. Patients fear constipation, doctors fear respiratory depression. Risk factors, anybody with heart and lung disease, COPD, heart failure, obstructive sleep apnea, especially if they're a CO2 retainer. And then if they develop upper respiratory infections or pneumonia, they may be more sensitive to the respiratory depression effects because they're already generally on the more tired side. Also, if they develop organ failure, so kidney and liver, because opioids are generally metabolized in the liver. Some are excreted hepatically, some are excreted renally, like morphine. Also, if they're on sedatives or have advanced age, if they're opioid naive, or if you're rapidly increasing their doses, then there'll be more risk of respiratory depression. So the first thing is assess, is this life-threatening? If the respiratory rate is down to 6, if they're hypoxic, obtunded, then this is an emergency. Yes, you have to give the naloxone. So obviously, if they're awake, you hold the opioids, remind them to breathe, put them on oxygen, and monitor them. But if they're not, you give the naloxone. But generally, you give 1/10 to 1/4 the usual dose, so 0.04 to 0.1 milligram. So you can do this by mixing 1 amp in 10 cc's of normal saline and then giving 1 cc. And this will reverse respiratory depression without blocking analgesia, and it will not make them go into opioid withdrawal. And this is something that I learned only when I was doing self-study for hospice and palliative care. It wasn't something I learned in residency. It's something that none of the residents who've rotated with us over the last 15 years have ever said, oh yeah, I already knew that. So this is important, not only for you to know, but for you to make sure that the residents know this as well. So if they're on call and they, the knee-jerk response would be, I'll give an amp of Narcan and I'll be there in a minute. But asking, are they on chronic opioids? Do they have chronic pain? Okay, if so, let's start with 1/10 of that. If that doesn't work, then give 1/4 of that. And if that doesn't work, then escalate from there. So important to know. You can also do infusions if you need to. All right, I think this is our, we're getting near the end of our time, but this is a man admitted to the hospital with an ischemic leg and gangrene, required amputation. He complained of such severe pain that the attending escalated his opioids rapidly. So he went from 0.5 to 1 to 2 milligram doses of hydromorphone over a 6-hour period. Initially, the relief helped, but then he was getting doses about every 2 to 4 hours. On post-op day 2, he was sleepy but arousable, but becoming kind of irritable, and he complained of severe pain all over with minimal touching. And it seemed that the more opioids he got IV, it just didn't seem to relieve his pain. So guess what? Palliative care was consulted. And we decided he has opioid-induced hyperalgesia, which is paradoxical hypersensitivity to painful stimuli, where you escalate the doses, but the pain just keeps getting worse, and it's because of upregulation of the mu receptors. Generally, they're hypersensitive. You barely touch them, and they seem disproportionately sensitive to pain. There's confusion, sleep disturbance, restlessness, irritability. Generally, it occurs within hours to days, but it may last for days. And it's generally seen where you rapidly increase doses or if they're on high doses of opioids. The treatment is opioid rotation, dose reduction, or using adjunctive medications like NSAIDs, for example. Non-opioids, you can use methadone, ketamine, or buprenorphine as well, if they need the opioid. All right, so one last topic before we're done. Opioids near end of life. As people approach end of life, there are some important dosing changes that need to be made. So this is a 92-year-old woman admitted to the hospital with severe abdominal pain and encephalopathy due to bowel perforation from underlying colon cancer. Both the patient and the family just want her to be comfortable and not suffer. So she got IV morphine, and 5 minutes after receiving the 4 milligram dose, she died. And the nurse was upset, and the family, they said, oh, no, the morphine killed her. So is that true or not? Did the morphine kill her? And I guarantee you'll see this on the boards. They always put this on the boards. They didn't put it on the medicine.
No, the colon cancer and bowel perforation did.
Right, right. So she died from her underlying disease. The morphine was to try to make her comfortable. So it's important to know that opioids, when dosed appropriately and proportional to the symptoms, do not hasten death. Morphine is not, quote unquote, liquid death, as one patient's family referred to it as. And ethically, there's this principle of double effect where the intention is benign. The intention is to relieve suffering, not to kill the patient. And the effect is, well, the patient died, but actually they died of their underlying disease. Even though the medication has a potential to reduce respirations, you know, if somebody's in a lot of pain and they're breathing 30 or 40 times a minute, you're not going to drop them to zero with the medication. So it's kind of a myth that people have. Well, you know, we could give you morphine, but you might die sooner, which is again a myth. Or you could stay more awake and suffer. It's like, it doesn't have to be those extremes. It can be in the middle where you get them comfortable and they actually live better and live longer than expected. And we obviously have an ethical duty to provide comfort. So death after opioids is due to the underlying disease, not to the medication, unless you give a whopping dose in somebody who's naive, for example. So near end of life, it's generally you'll need to reduce the dose unless they have a reason to have escalating symptoms. So because of dehydration, low oral intake, low albumin, renal and hepatic failure, or fevers, generally you can use a lower dose and spread out the interval between the doses. If they're oliguric or anuric, then use mainly PRN short-acting medications and avoid codeine, avoid tramadol when the renal function is low. Avoid long-acting morphine or oxycodone. Alternatives to morphine, fentanyl is really the preferred one in renal failure because it is not renally cleared. So you can dose it and it doesn't build up or cause myoclonus or toxicity, neurotoxicity. Methadone can also be used, again, probably a very low dose because it's very potent. Buprenorphine. And then hydrocodone or hydromorphone may also be used, but again, you'll want to reduce the dose by at least 50%, maybe even 75%, depending on how bad their organ failure is. And then also changing the route. If they become cachexic or have dysphagia, you can use other routes. So sublingual, rectal, IV, sub-Q, transdermal options, or oral options like the liquid. There's liquid morphine, which is called Roxanol. There's liquid oxycodone, which is what do they call it? Like
Roxicodone or something like that.
Yeah, Roxicodone, Oxyfast. And then methadone, it's called the methadone intensol solution, which is 10 milligrams per ml, and that also can be given sublingually. All right, so in summary, I hope that you've gained some understanding on how to individualize, have a person-centered approach, including patients with impaired communication and the use of the pain AD tool, which is built into a lot of electronic medical records. And then identifying non-opioid and particularly opioid-based approaches to pain management, including how to dose, when to dose, how to convert, and then how to change dosing as people develop organ failures near end of life. And then also identifying common options for treating refractory pain. Are there any questions?
Any questions for Mike? Comments? I've got one quick, just follow up. David asked the question about the pelletized long-acting morphine. And years ago, there was a product that came out with the brand name of Katie. There also was another one called Avinza. And they both had the same thing where it was like, I think of the old time contact cold capsules where you just pop it open, all these, hundreds of tiny capsules sort of thing. And so that actually was a long-acting morphine that you could uncapsulize. The problem was, you mentioned tubes. There many times I saw those things just get really, really clogged in the tubes. I finally had a patient that came in and found some sort of an over-the-counter smoothie preparation, but it had to be this one particular flavor because it didn't have any seeds from berries. And he could mix the Cadian in that and get it through the tube. For the most part, it's very, very difficult. It's also very, very expensive. And so for that reason, I haven't seen Cadian used in years and years and years. But technically it is on the market and it is available. Where I have used is those rare circumstances where you want to keep someone on morphine. They can't swallow the pills, but you can take the capsule, take it up and put it in a little bit of applesauce and it'll go down just fine. So Mike referenced and I don't think I mentioned this last week, referenced our YouTube channel. And for the new fellows and those that are not aware, we archive all of these lectures on a YouTube channel. It's West Michigan HPM Fellowship. If you just put that into your YouTube search, it'll come up. You can subscribe to that so you get the notification every time one is posted. But we archive everything there. And they're accessed on a regular basis, so feel free to do that. And also, I think I mentioned last week also, with the invitation that includes that link to the lecture, also has a document for submitting for CME. So if you need CME credits, that's there as well. So great job, Mike. Appreciate you doing this and sharing with us.